I do believe that HR professionals really need to step up and understand that healthcare strategy is as important as a sales plan and operations plan for their organization, and they cannot take a back seat to this any longer because they are fiduciaries of their plan, and they have to understand this because they can impact so many lives by being better stewards of their healthcare plan.
So you're supposed to save the mic drop for the end of the podcast. And so, Rachel, why don't you kick us off, if you don't mind? We'll go down the line. Who are you? What do you do? And how come you're here today?
Of course. First of all, because we're live, I thought we'd have signs for our audience, when you say, oh, wow, that was insightful. There's high
Applause,
expectations. It's like with a live audience. My name is Rachel Strauss. I have been in the pharmacy benefit space for 23 years. 2 months ago, I had a Jerry Maguire moment and left a career that I'd had for decades to really continue being a voice in our industry. And I started PBM Princess LLC, really to make this understandable. This is a very difficult industry, yet it impacts everybody in some capacity. And so I really just feel so passionate about helping make people understand why PBMs are what they are, how a good PBM can work, and that's really my why for being here today.
I want to know, how did you get the name PBM Princess for people that don't know?
Yes, well, during the pandemic, I had a lot of pink in my office. I wear pink. It wasn't always the color I wore, but I just happened to be wearing it a lot. And Lester Morales, on one of his early podcast days, introduced me as the PBM Princess, and I kind of didn't hate it, so I was just like, oh, that's so embarrassing.
Kind of didn't hate it or loved it.
And it was like, so embarrassing. But then I was just like, yeah. And so I just earned it. I just owned it. So here I am.
I love it. The PBM Princess. What about you, Stephanie?
So, hey, everybody, and thank you so much for being here. My name is Stephanie Koch, and I'm the Director of Human Resources for Hendry Marine Industries, and we're based out of Tampa, Florida. And, we got Tampa in the house. Love it. All right. Yeah.
Applause. You did it.
I know. It sucks. Yeah.
Thank you. No. So I've been working in human resources close to 30 years, and I have seen a lot of things because in reality, I'm a generalist. So I've done a lot of different things in the HR department, including running them, of course. And about 10 years ago, after going through different variations of being fully funded with different organizations, as well as then transitioning to learning self-funded, which I have to admit was scary, that first time transitioning, to then going into a healthcare system that we consider the disruptive or non-traditional, with reference-based pricing and an independent PBM, and doing all the things that really companies should be doing. And since then, that was about 10 years ago now, and about 2.5 years ago, I got asked to speak at a conference, and my first question was, in public? I never thought I would speak in public, and that is a true story, and I was terrified, but then I found my passion. And my passion is to be an advocate for HR leaders and organizations throughout the country to better understand and comprehend all of the opportunities they have to make their healthcare plans better for their employees and their family members. So I've been on a mission, and I'm going to continue.
Well, and she's been really vocal, and I have to give Stephanie some shine as well, because she actually had the single highest listenership of any episode of our podcast last year. So phenomenal. I know you were surprised when I told you, but I wasn't surprised at all after sitting down with you, and so I wanted to at least give you some kudos.
I appreciate that.
You're live on the show. So Kristen, we'll go down to you now.
So much of what Stephanie just said really resonates. So I'm Kristen Rivers. I've been at Pareto Health for about 3 years now. My role is to run the West region. And when I started, I think I had 2 RVPs on my team, and we've been growing and trying to disrupt the market out West. Prior to coming to Pareto, I was with United Health Group for a little over a decade, we'll say, because when I say 14 years, it sounds like a very long time. And I was in the pharmaceutical space prior to that. And I'm a recovering lawyer. Yeah. So don't hold that against me. I think what I did was go to every hated company and industry before I came to the right side of the fight. But I did not do timeshare sales. So at least I don't have that.
Awesome.
What I will say is, being at United, when I was in a sales capacity before going into leadership, we got to do really cool things for very large employers, right? Customize their benefits, really design their entire offering to answer their business needs. But we're talking about 1,000, 10,000 plus enrolled employers, hospital systems, domestic fee schedules. When you started to move down market, even under 2,000 enrolled, everything was off the shelf. Nothing actually helped the employer do anything differently. So much of what Stephanie just said really resonates. What can we do to really help empower employers to get to offer benefits and use it as a tool to really help their people and do things differently, instead of it being a detraction tool or something that's dictated to them by a carrier? And that's one of the reasons I came over to Pareto, was to be a part of a company that has a mission to help employers of all sizes get to do what the largest employers do.
Well, and last but not least, thank you, Kristen. And speaking of empowering employers, I don't know if there's a better voice on LinkedIn that I've seen than Kimberly Carleson here. Kimberly, you can tell us what you do, but if you don't follow her on LinkedIn, obviously follow everybody. I can assure you every one of these panelists is going to give you value. The stuff that she posts about things she's seeing in hospital bills and the egregious overcharges and how to work it, it's just phenomenal information. And so I wanted to commend you for the work that you do there. But why don't you tell us who you are and what your company is, Kimberly?
Thank you, Spencer. It's a pleasure being here. So I am CEO of US Beacon. We are a medical claims integrity review company. So we review medical claims for ineligible charges. I got into this space when my husband was diagnosed with stage 4 cancer, and I had to be his biggest advocate. So when we started getting claims in, we noticed there were charges on there that were not quite familiar with us. So we created a company that works for people like us and companies that have employers like us.
And what's the stat? You say you've seen one single claim?
One claim
ever.
That's been
and
claimed.
How many hundreds or thousands?
Hundreds of thousands of claims. I can't even count how many, but we've seen one without errors.
Yeah, that's amazing. Well, so guys, I'll go ahead and say this out loud in case somebody's listening to this online instead of here in person. I'm Spencer Smith, SVP of Sales for Pareto Health. I run our South Central. Thank you, Jonathan. He didn't get the slow clap started, man. I wish he had. But I do appreciate you being here. Of course, I'm the host of the Self-Funded with Spencer show as well. And the reason we do these live ones is because, one, I mentioned the networking component, which I think is really important. But we also want to give you guys an opportunity to attend a show and ask the questions that might be burning in your minds, whether something that was prompted to you while listening, or you came here going, I want to make sure to ask Rachel about this. Like, we're going to give you a chance to do that at the end. We'll probably have 15 to 20 minutes of Q&A. And just fair warning, if you do ask a question, you're going to be on camera and you're going to make the podcast. So if that makes you nervous, I get it, but it just wanted to give you guys a heads up. But ask away, no question is off limits. And so let's start, if you guys don't mind, at the very beginning, right? Let's give the audience a sense of like State of the Union, right? When we say status quo or what we're fighting against, and this is an open question, I'm not just going to go down the line like an assembly line. What is status quo healthcare in the United States, or what are some of the constraints that places on employers? Let's go ahead and define that for everybody here.
Well, I'll kick it off just because I think status quo is thinking employees want one thing and not listening to what they really want. You know, I had a conversation last week with a physician who told me that he's sick of the phrase healthcare is broken. And I've used it on LinkedIn. I think we all have in some capacity. And he said, look, healthcare is not broken. We've cured Hep C in the last, decade. It's the way we're paying for healthcare that's broken, and it's the expectation and employers not understanding. And I believe to, say status quo is, last year with the tragic murder of the CEO of United Healthcare, people came out. There's a Broadway play about it. It's crazy how many people have idolized this kid, martyrized him, who did this unspeakable thing. Yet, when I was with a small independent PBM, the number one reason I lost RFPs that year was because I was told by brokers the employers wanted United. They wanted Blue Cross. They wanted the big carrier. And so status quo to me is if you've got hundreds of thousands of angry people not happy with the way healthcare is paid for today, why is that the card that every employer thinks is in their they need in their wallet?
We hear this all the time, Rachel. I want to comment on that. We hear this all the time. Oh, but my employees, they won't have Blue Cross on their ID card, right? Or insert other carrier name here. They have this affinity for a logo, and they associate healthcare and health insurance with that logo on an ID card. And whether or not it's actually true that you took that away from an employee or changed that network or went to a non-network solution, they don't really care, because all they're concerned is, I don't want to disrupt my employee base or make them angry, because the perception is I took something from them. But all it really is an ID card with a logo on it and a reimbursement schedule that they have no insight into. And so to me, status quo is that affinity for that iconic logo, and there's nothing more behind it than that.
Right.
In a world where they're all hating it on social media. And that's what doesn't make sense to me.
Yeah.
I completely agree with that. The way I see the status quo, it's a huge issue, because from the employer perspective, I'm not speaking about Hendry Marine, because I'm really proud of the healthcare plan strategy that we've built, but organizations that keep renewing and doing the same thing again and again, I call it the definition of healthcare insanity. So they're doing the same thing, but expecting different results. That's the first issue. Then we have millions of Americans that are in debt because of medical bills, and they can't afford it. Which is the third issue, is accessibility, and essentially employees that have insurance, they're functionally uninsured because the employers can't afford premiums that continue to go up, so they cut the plan designs.
Yep.
And typically the plan design suffers by increasing deductibles and out-of-pocket maximums. Therefore, basically, you're diverting your employees from actually getting the care they need. So it really makes no sense, staying in the status quo and expecting things to change. So if employers don't start opening their minds to understanding opportunities to not only have better health care, but it helps with recruiting and retention and so many other functions of their organization, they're
Stephanie, you said something I want to come back to later, especially because we've got the employer voice here, is how do we get employers like you that at one point were fully insured and perhaps stuck in that arrangement? What caused you to finally lean in and open your eyes and then decide there's a whole world out there that I could change my benefit plan to the benefit of my employees? And so I want to keep that as a core subject. I want to let Kimberly and Kristen add some color to the State of the Union question first before we go there.
Okay.
Yeah, so thoughts there.
So I would look at the status quo as the lack of education that exists in the system today. Yeah. The system is designed to be complex and difficult to navigate and difficult to access from a member's perspective. Add the complexity from an employer's lens, whether it's an HR, CFO, owner, or C-suite executive. Their day job is not to understand the complexities of the healthcare system, but they do have to now, right? Considering where things are going, healthcare costs are going up. Premiums are getting unsustainable. Yep. To Stephanie's point, the only levers to pull in a fully insured setting are a detriment to the people on the plan.
Yes.
And what was the purpose of offering benefits to people in the first place? It was to have a way to attract and retain talent and to give them something that's different, to bring them to the companies that are best in class in their field and be able to compete and get the right talent. Now, to Spencer's point, the education that's happened is through being, I would call it, brutalized in the system. People go, well, when I had blue on my ID card, I went to the doctor and this was approved and I was able to get my medication. Now that it says Aetna or United on my ID card, I can't do that anymore. And they associate the logo with how the benefits work, not the benefit plan design with it. And that distinction, I think there's a lack of education in the system that drives I'm going to have this false sense of loyalty to either a carrier or a system because I don't understand the other things that are out there. And I don't know how to go about educating myself to be able to make the right decision for my people and my plan and their families.
Well, Kristen, that point, I shot a podcast earlier today with the founders of Medify, and they said a stat that actually was pretty astonishing. They said from the millennial generation, 25% of millennials said they would rather clean a toilet than learn about benefits. Literally, that's how little they think about or care about benefits. They'd prefer to clean a dirty toilet. No joke, right? That's a real stat. And so when you talk about the association with an ID card and they get frustrated when they think they lose access because that was a non-network doctor and they think that's benefits, it's because I think there's a very low interest level with the general population to even care about this stuff at all until it actually affects them in that emergent moment.
I see that all the time with my employees for years.
And give me some examples of behavior.
So, for example, every year for when we are trying to educate the employees during open enrollment meetings, and we do what I call the dog and pony show, when we bring all the vendors in and we HR are taking almost a whole week of our time trying to educate the employees. And it's not just one time of the year. This is an example. And we are very thorough in the education and the benefit guide and the plan designs and what have you, and explaining as much as we can, but yet they leave there and the next day they'll ask, oh, who are our benefits with? And because they don't pay attention until they need it. And the example is that like a month later, something will happen and they come in or call and they're in a panic because they didn't remember or retain anything we told them.
And do they get mad at you too as an employer as if it was your fault?
No, typically not, because we're helping them. And obviously that's our role as HR leaders and support is to help them and guide them. But I actually stopped doing open enrollment meetings a couple of years ago because I felt our time was better served focus on the employees or members that really wanted to understand it rather than spend a whole week of time doing meetings that nobody was listening to anyway.
Yep.
Having spent years working alongside healthcare leaders, brokers, and employers, I know how overwhelming healthcare can feel for our customers. We've all been there. Those renewal conversations that never seem to get easier. Rising pharmacy costs and medical costs, and no real transparency into where healthcare dollars are going. That's why I'm excited about Nomi Health. They're not just fixing the old system. They've rebuilt self-funded benefits from the ground up. With Nomi's network, you can offer something truly different. No copays, no deductibles, zero out-of-pocket costs when members see a provider. It's the kind of benefit that makes everyone ask, why hasn't healthcare always worked this way? Ready to bring your clients something different? Visit nomihealth.com and see how Nomi is rebuilding healthcare, one employer and one community at a time.
On that subject, I want to hear Kim's thoughts. What are some of the things that you're struggling with? Because I know you have a specific niche in which you do a very particular thing for a health plan. But what sort of commonalities are you seeing in errors or some of the most egregious things that you're seeing? I'd like to actually highlight the type of work you do so people can comprehend that.
Sure. So really, I see a lack of understanding of what's going on. I was on the phone yesterday with an employee that had a denial, and we were working through with the carrier. Do y'all get those confused? Sometimes it's like there's so many pieces of the puzzle. There's the carrier, the broker, so we're working with the carrier. We are talking to them and asking them about the denial, and she had to go to an independent third-party denial. So I asked, well, who's the independent third-party denial? And they named the company, which I'm not going to name, but it was someone that was within the company. So I said, there's no independent in there. So I think it's super important to make sure that there's no misaligned incentives and that the company truly has independence from who they're letting deny.
Yeah, it's a proverbial fox guarding the hen house is what you're describing, right?
Exactly.
And is there independence in name only, just like transparency in name only as well, which I know we're going to touch on. And why don't we go ahead and do that now? Because I think that's a buzzword, and I think everybody in this room would be in favor of transparency, right, if I ask you that question. The problem is we can't define what that actually means. And transparent to what? To what end? We're transparent. Okay, great. Transparent in the way that you're conducting business the wrong way or have improper incentives, or what does transparency actually mean? And so I would love, especially in the world of pharmacy, I know transparency is a buzzword. What should that mean, Rachel?
I think ultimately the biggest issue in the PBM space has been, transparent or not, you can't track the dollars. You can't figure out who made what, why decisions were made, where, for years PBMs had no admin fees, and it was like, well, then it took somebody to say, well, how are they getting paid? And it was like, well, we get paid. And I think, and the problem with PBM, I would argue that if the price was the price is the price and they're making money, I wouldn't have a problem with that. The issue with PBM is the price is never the price, because there's rebates, there's things that come back, there's this, there's what did they pay the pharmacy, who else got paid, and it's like, into the consumer, there's two consumers in a PBM, right? I mean, simplifying it. There's the person writing the check to the PBM, and there's also the patient that is paying a copay or a high deductible health plan towards their prescription drugs that they're picking up at the pharmacy. The patient wants to know what they're spending, right? There's a pretty finite example, but because transparently, if their drug is cheaper than a drug that's more expensive, but yet their copay, they can't track it. Yep. And so I think transparency in the PBM world, what it means today is whatever the PBM wants it to. The definition alone isn't transparent. And so to me, it should ultimately get to a place where every decision that is made by a PBM is clear and is not, to Kim's point, a misaligned incentive.
Well, let's carry that down to a logical conclusion here. If you were to define transparency as the PBM princess, you get to make the rules in the pharmacy world. What would you want that to actually mean? If that chain of events, what can we chop out, or what can we kind of massage to get rid of to ensure that it is truly a transparent cycle?
I mean, I'm probably not going to be real popular amongst PBMs with this opinion, but I'm getting to where, after I've seen what I've seen even in the last few months being on this side, to where a PBM really should just be processing claims. And then the entities that are there for cost containment or, can align their incentives with other components of the plan. To me, you can't get more transparent than having a per claim fee to process the prescription drug and remove yourself. That would be the easiest way to get transparent in the PBM space. And I'll finish with, because the question could be, then why do we need PBMs in the first place? I do believe you need a PBM because there is a measure of safety knowing. Otherwise, if a member fills a drug at CVS, and here in Texas, we go to H-E-B, and then they go somewhere else, well, those pharmacy chains don't have to talk to each other. There has to be an electronic correlation of all those claims that one patient gets for efficacy and safety. And that should be what a PBM does, is look at the claims that are being processed. But with all these PBMs in the space, everyone's got a new bell or whistle or toy, or look what we can do, and we do this, we're best in class at this. But yet, what are they not best in class in? And where is that leading? What rabbit hole does that lead them down? And that's what I'm seeing.
Yeah. And Kristen, same question to you, right, in the form of transparency. And I know we're obviously we're both at Pareto, so let's go and just say that out loud. But one of the jobs that we have is getting employers to a point where they're even open to this idea of seeing data in the first place, right? And when we'll talk about data and how to use it, but they don't know what they don't know. So when you think, oh, look, transparency, you're going to get to see all this information, they go, well, what information? Am I supposed to get information? They don't know what we're talking about. So how would you define it then?
So I think transparency from an employer's lens has to be, they get information, actionable information, and working with the right consultant partner to help them understand how to deploy solutions to do something about that. So as you know, I oversee a lot of markets that are very fully insured, saturated markets. We talk to employers every single day who do not even know what self-funding means, what a specific deductible is, what claims data even looks like, because they're sitting in pooled products with the carriers. They get one large claims report with their renewal that has neoplasm with a dollar amount next to it. And that's the level of information they get and say, by the way, this now justifies your 40, 50, 60% increase that we're giving you. That is what they've been trained to accept in 12-month increments. Employers, from a transparency, needs to be that they are empowered with information, working with the right consultant partner to help them understand that information, because we can take a bunch of information and claims data and dump it on them, and they're not going to know what to do with it because that's not their day job to decipher it. Their consultant needs to be their guide in helping them understand the information, know what strategies they need to deploy, by looking at the historical claims and looking at where their trends are going, to help them actually effectuate change on their plan by both enhancing benefits, to Stephanie's point earlier, and helping them save. They don't have to choose between the two. Yep. And I feel like that's the common misconception, that if we save or we do cost containment, that means it's going to be a takeaway from our people. And that is not the case in a self-funded setting.
Yeah. Have you seen that, Stephanie, on your plan where you actually are improving the benefits over time while saving money simultaneously?
Yes, so that was something that we're really proud of, because we have been able to move from originally fully funded to self-funded and then make a total shift over to reference-based pricing and really have an impact on savings. But we held our premiums for a few years. In 2021, we had a surplus of $1 million. We invested in an on-site primary care clinic with walk-on clinic, and Mike Tauber's here, he's cheering.
Yeah.
No, so they have been a wonderful partner of ours, but that point is that we have data. We have the ability to see what's happening within our plan activity, so we can then mitigate and shift and pivot where we need to help, other claims that might be coming in the future. So I learned so much from, being around a lot of you guys the last few years, and it's really helped me be a better advocate for my employees. But the one thing that I want to really emphasize here is, while HR should work with their consultant, and their consultant might want to be the heavy on helping them make decisions, I do believe that HR professionals really need to step up and understand that healthcare strategy is as important as a sales plan and operations plan for their organization, and they cannot take a back seat to this any longer, because they are fiduciaries of their plan, and they have to understand this, because they can impact so many lives by being better stewards of their healthcare plan.
So you're supposed to save the mic drop for the end of the podcast. That was excellent. Yeah. And Stephanie's out. Yeah. But I mean, very well said, right? And I think that's a really good segue into getting employers to lean in, right? And so you've obviously done that. You probably were reluctant at first. Kristen and I deal with this every day, and I'm sure Kimberly and Rachel, you guys see it as well. But now's not the right time. Or but I just don't know if there's enough savings there. Or I don't know if I have time to do it. Or I don't know if I have the manpower or the female power to be able to do it, to manage this plan. And so they come up with every argument or objection under the sun to stay exactly where they are and keep themselves in the spot where the next year they're going to have the exact same outcome again. How do we fix that?
Well, I mean, first of all, I think you said it, Spencer, we don't know what we don't know. So it's not as if, we're officially or formally trained in healthcare or benefits. We learn benefits, right? And usually it's lumped with benefits and compensation. And I think it's kind of diluted the actual topic of healthcare strategy as its own independent function of human resources. And it has to be looked at and viewed through a new and different lens, where HR is partnering with finance, and they are working in tandem, because they each have their own goals they want to accomplish, and they can come up and have mutual goals and each walk away, very happy, because they'll satisfy both of the needs they have. Finance wants to save money, right? And HR wants to make sure the employees are taken care of. When you have conversations that are productive and put everything on the table, that can happen. but there is definitely reluctance because we don't know how to overcome the fear of doing the wrong thing, making the wrong decision, and maybe it's the company not supporting HR enough to provide that support and resources that they need, or somebody is a broker buddy of somebody else. And, there's a lot of variables that, can really impact why HR is not doing the things they need to do.
ClaimDoc is a medical claim auditing and member advocacy company. We provide fiduciary services to employer-sponsored benefit plans, and allowing them to create an environment where we ensure that the benefit plans are being charged in a fair and reasonable basis.
My business is basically people, and it become a real simple transition. We thought it was going to be far more complex. I've saved, we'll say, hundreds of thousands of dollars. I could not say enough about ClaimDoc.
Chris, yeah, I feel like you want to say, and Kim, yeah, please after that. Yeah, go ahead.
Yeah, I think what you're hitting on is exactly what we need to do. We have to empower employers, HR leaders, CFOs, the key decision makers within companies to understand what's happening and make informed decisions, right? If we end up down a path of pitching them a solution, we're going to hit the benefit objections or the objections to that solution. It's too hard. I can't do it. I don't have the bandwidth. The list that Spencer just went through. I think one of the most effective ways to deal with that is to take a step back and start with education around misaligned incentives that Kimberly was hitting on earlier. This is giving them a good understanding of what's happening on their plan today before we jump into what the solution is. Learn about them, their organization, what their objectives are, how they make decisions,
Completely agree.
who the key stakeholders are, and show them what plan they're in today, what health plan they're in today, and what that is doing and how that's going to be their cost drivers and their benefit drivers or benefit detractors to their people. When you pull the curtain back a little bit and help them understand how things are working today, a pain point gets created. Or maybe they thought they didn't have bandwidth, but now they're going to find a way to do it because they're not satisfied or they're unhappy with the system they're in today. If there isn't a driving factor or a motivating factor to get them to make a decision, they're not going to.
Correct.
They're going to hit the easy button
Correct.
and move on to the next thing that's a burning, priority for them.
And do you know how hard it is? Plans will fulfill their fiduciary responsibility by doing a one-year audit. You're getting that audit back. You're finding that you're overspending, but then you do nothing about it.
Yeah.
And coming in as an independent company with no ties to anyone else is very difficult for us because there's always those incentives. If you're tied to someone, someone's getting paid on the back end. So I think plans, if you're getting an audit, let's look at those audits and let's act on them. Instead of sitting back doing
Yeah,
nothing.
what are some of those
checking
basic
that box
actions?
on fiduciary.
What will be some of those basic actions, right? So you come back with an audit, you discover, hey, there's overutilization here, there's overcharges there. Like, what are some basic things that an employer should be doing now that they have that information?
You should be reviewing your claims, and you should know you own your data. You own it. There's laws in place to review your claims and get the contracts. There should be no secrecy. If there is, that's when you should find someone else.
Find another consultant?
That's right.
Yeah.
Find another. Yes.
But I think to that point about the consultant relationship, and I started hitting on this, and this is a sticking point because I've been there, where there is a relationship with the broker that they may have with the CEO or CFO, and we as HR professionals are sometimes stuck, and we can't make a move because of this relationship. And I think it's important for HR to really try to stand up and bring solutions forward, that could be financially rewarding to the organization that overall impacts the employees.
Well, and I see a couple things happening in the consulting community. One is an elevation of the standard and what's required of them. So the bar is continuing to be raised of what they're supposed to do. But I also see an expansion of the responsibility set that's also falling on their plate. So gone are the days of a strong relationship. You shop the market, you're friends with them, you go out every once in a while with families, and then you go back and you don't worry about it for another 12 months. Obviously, that standard has been raised. But they're getting into the role of consulting on benefits, consulting consulting on technology, consulting on pharmacy, you name it. There almost need to be sitting co-chair with these business owners as they're running these businesses at this point. And so I do worry, though, that the expansion of that responsibility set is going to put too much pressure on those consultants where the standard is so high, they may not be able to meet what we expect them to meet at some point as well. Would you want to comment on that?
I have a quick comment. It's, you reminded me there years ago when I was, not early on, mid in my career with a PBM, my former career, we were one of the first PBMs that were doing patient assistance and all of the specialty drugs. And, we had a thing that we had never paid for a Hep C claim at EHIM. This was in the early days because we were successful. And we went to an HR conference and it was, amazing because we got a booth. We're all excited. We have a statistic. Everyone's afraid of these $100,000 drugs. I mean, I know today's day would be like, hold my beer because drugs got real expensive. Yeah. But back then that was a scary amount. 3 months, $100,000. And we were there to tell people, you don't have to pay for this. And every person we met at that HR conference said, you know what, you got to go to my broker. We don't make these decisions. We don't have the ability. And so it's amazing to me because I think that, so yes, we have to be partnered with our brokers, but for those of you that are HR or CFO in the room, this has to be a partnership. Yes. I can say the groups, ironically, in the Midwest, which is where I'm from, you have a lot of Taft-Hartley, you have a lot of unions, but they all create benefit committees and they listen to their members. What do their members care about? And it's not necessarily the name on the card, it's the benefit themselves. And they discuss this with with the management side and they negotiate and they go back and forth before the plans are built. And so I think what you're getting at, it just struck a chord because when you said HR has to care, I can't emphasize that enough because that is how you start to make change and how consultants that are in the room, and there are some outstanding consultants in this room that I see, they are listening to HR and not everybody does. And I think that is such a, because not every HR says what they want and what their people want. So I just wanted to share that.
No, thank you for that. So why don't we'll dive into your world for a moment, Rachel, if you don't mind. You don't have to go first, but I want to dive into the world of pharmacy is in the news a lot right now. The PBMs are under obviously intense scrutiny. There's some recent legislation that came out addressing some practices in pharmacy. And so I want you to maybe be able to comment on the role that federal versus state legislation plays versus private sector just solving some of these problems without the need for government.
Well, I'm going to start this with a segue because it's how me and this lovely lady on the end became BFFs. And that is, I think the states are really who are kicking butt with pharmacy benefit, reform right now. It is not happening at the federal level. It's talked about. People are in DC. You can Google it. And yes, it is. I feel so cool because it's like PBM is in the news. And for the first time ever, people not in our world are starting to say, don't you work for a PBM? No offense. People for years have thought I was a pharmaceutical rep. I'm not a pharmaceutical rep, but give it that. It's now in the news. It is our opportunity now to explain how this business works. And so when you have laws, and I'm going to give this to Kim because it just happened in Arkansas. You talk about misaligned incentives. Why don't you kind of explain what your lovely state recently did?
Are being sued by some of the major pharmacy chains because we are not allowing the PBMs to own the pharmacies any longer. So we're keeping our mom and pop pharmacies alive.
Yeah.
And that's...
And so what are you seeing actually on the ground, though? I mean, I realize that legislation, has it actually passed or is it what?
Yes,
okay,
it
so it's
has
passed.
And
so
there is a lawsuit.
Are they closing? Are those?
They have claimed they're going to close.
Okay.
I have not seen them close yet.
Yeah.
I have not used them in years. So, but they have claimed they're going to close.
They for those pondering would be CVS.
Yeah. So
and Walgreens, of course. But I saw the only issue, and this is where we could go in circles, and this could be like we could be self-funded with Spencer's 200 to 400th episode just on this topic. But you've got to, and again, this gets into who should be making the money when prescription drugs are filled, because this was truly passed by the independent pharmacies. The one issue that you're going to have, and where CVS is not totally wrong, is that you're going to have what you're going to call pharmacy deserts, where there are going going to be areas geographically where people cannot fill a prescription drug. So I get why it happened. And, and I think it made a stance. And what the focus here is on these misaligned incentives, on these vertical integrations that are happening where companies are just buying, and they're vertically aligning all of their profitability in PBM. And that's what's got to stop, because CVS should not have to close their stores. The problem is that Caremark was mandating or making it more incentivized for patients to use CVS. And that is what was not fair to those independent pharmacies. And that's where, but in Arkansas, the only thing they could do to hammer it down was make the decision that they made. But there could be a detriment to the actual people in Arkansas that do not live close to a mom and pop. Now, in hopes they'll reopen and there will be more businesses to be had by independents. But I think, to get back to the core of this question, and I'd be curious, from both of your standpoints, what we're seeing right now is unprecedented opportunity to keep talking about what is happening, especially with the big, I'm going to say big four PBMs, because we are here in Texas. The big four being, of course, Optum, Caremark, Express Scripts, and then here in Texas, Prime Therapeutics. And so with those four pharmacy benefit managers having so much market share, and everything you're seeing reform-wise, for the most part, is attacking those PBMs. And employers are listening. I can tell you here in Texas, we have the Texas Coalition Business Group on Health, where our Fortune 50 companies here in the state have all taken a pledge to, this is a lot because of Mark Cuban, which I know is local here, but they are taking a pledge to leave these big four PBMs in the next 2 years. And so we just need to continue getting employers like you to keep speaking about what they see when they leave, because the more employers talk about it, the more opportunity we have, and Washington and our state governments are listening.
Kristen, yeah, go ahead.
I would add, and then I'm going to bring it back to the employers and the choice that they can make in order to be a catalyst to change here. There's, from more of a macro view, there's a lot of lawsuits that are forward in general. In addition to the legislation that's going on state by state, there's a lot of lawsuits that have been brought forward. And for some people, it's been disheartening, right? This lawsuit happened, here are the things that happened, and then it was dismissed. That's disappointing. We're not going to see the change we need to see in the PBM space. I'm actually of a different opinion, because I think what each of those lawsuits are doing is it's setting up legal strategy. They're getting the court to rule a certain way and start to narrow the scope on what they're defining. Even though they dismissed the lawsuit, they've issued an opinion. Then the next one comes. Then the next one comes. This is legal strategy set up to change this in the next 5 to 10 years. So we get very focused on the one and then disheartened, and then the next one comes and then disheartened. But watch how the courts are ruling, even though they're dismissing, is going to inform what question they're bringing forth in the next lawsuit.
That was good.
Yeah, that
was really good.
Yeah.
Lawyer.
Bringing it back to the employer, what we're going to start to see in addition is the carriers aren't going to take this sitting down, right? A lot of states have anti-competitive action happening. You don't get access to our network under 250 enrolled employees unless you take our PBM. Sorry, Mr. or Miss Employer, your entire population can have a mutiny on their hands. I was actually working with one of the employer groups that's with Pareto today to help them do a SPD and pharmacy contract review to compare. And they had to have a specific network. So they were forced into that PBM contract. It's taken 2 months to get the PBM contract. This is a self-funded employer. 2 months to get our hands on the contract, to try to make sure that it's aligned with the SPD. And what is the next step, right? It's usually litigate, bury, buy, however the carriers typically approach it. When states start to take a stand, there's going to be anti-competitive action that's going to come, informed by the decisions they've made in certain states. Mm-hmm. And employers have the power and ability to stand up and say, great, I don't want your network. I was going to use another word. I don't want your network. I will change networks to ensure that I can have the flexibility to bring the right solutions to my people. I'm not going to be handcuffed by your rules.
Well, and that begs the question then, I get the association of a network with a PBM when they have an entity that owns both or there's an affiliation between the two, but what does a network actually have to do with whoever the pharmacy benefit manager is? Why should those two things be entangled at all other than for business reasons, right?
Misaligned incentives.
Misaligned incentives, right?
They shouldn't.
It's going to be empowering employers, misaligned incentives. It's going to be the subheading here.
Pareto Health is the largest benefits captive in the United States. With nearly 3,000 captive members, $1.3 billion of stop-loss premium in force, and almost 1 million covered lives, no other benefits captive comes close to Pareto Health's scale. But it's not just about the numbers. Pareto Health is a mission-driven organization, and that mission has two distinct parts. Number one, to make self-insurance simple and more accessible for small to mid-sized employers. And number two, to arm them with the most powerful cost management tools on the market. So if you're an employer frustrated with your healthcare outcomes, or you're a benefits consultant looking for an alternative to the status quo, it's time to consider Pareto Health. Pareto Health, where employers come to do self-insurance right, to do it easily, and to do it at scale.
But Stephanie, I'd love your opinion here on this subject, especially because I know we talked about reference-based pricing. You guys use the walk-on clinic. You guys are self-funded. What about the pharmacy side for you? Like, what changes do you guys make in your plan?
So we actually, we are responsible fiduciaries. And one of the things we did between 2024 and 2025 was we did reevaluate our PBM relationship. And in looking at it, we were in a model that was not actually the most beneficial for us. So we went ahead and made a change in 2025. And, we're proud to work with VerisRx. They're here as well. I've got my whole ecosystem here supporting me.
You bring everybody with you? Yeah.
They follow me wherever I go. I don't know. But, the things that we were looking at, because we have access to data, so we were seeing things, for example, like Skyrizi. It's a very, very expensive medication. And, I'm looking at the claims and I'm saying we're paying $35,000 for 2 doses of this one medication. What would this look like with another relationship? And the other part of it was evaluating, how many more opportunities did we have for our employees to save money out of pocket because of a broader international, scope that was available through the new relationship. And another thing we always do is we connect everything to our on-site clinic. So our PBM is connected to the clinic. Mm-hmm. But I think it's really about awareness and understanding how your healthcare plan strategy works.
Yeah. Well, and to no fault of the employee's own, the tiering of the formulary incentivizes sometimes these very expensive medications because it's actually cheaper for them to fill those instead. And so they don't know that they're taking a $35,000 for 2-dose drug. They just know this is what the doctor told me to take, and here's my copay.
Right, but I think it's our responsibility as a fiduciary to make sure that we're spending our money prudently.
Sure, yeah.
And even though it is that costly drug, and that's one of them, we want to make sure we're looking at all of the resources available. We're also looking at, we have people that are having to do infusions now, and they're very costly. And okay, next year, what does that look like for our plan design? Is it going to be a step approval process where, unless medically necessary, you're either going to do it in an infusion center or at somebody's home, at your home, and you're not going to be doing it in the hospital anymore, because in the hospital it costs us, and this is a true story, $47,000 every time, and that's 2 times a month.
2 times a month?
Correct.
Jeez, okay. What's that, $850,000 a year?
Yeah, it's a lot. And, so that's the thing. So we have we have the accessibility to this information to problem solve.
Yeah.
So for employers who don't know that they have access to data, it's really unfortunate, because that is your pathway to really helping solve not just the financial issue for the company, because I'm going to advocate for my employees, but it's to give them better healthcare opportunities.
Well, so let's move on subjects, and I don't even really need to ask a question. I just need to say the phrase GLP-1s, and then we just go, right? Because I feel like this is an unavoidable conversation right now, very popular to discuss over the dinner table, see commercials. I'm sure employees are sharing about their experiences with them. But what we have is an industry trying to figure out how to pay for these things, right? And so what is the right way to organize a plan? Should they be covered for weight loss alone? Should they be tied to a diabetes management program or a lifestyle management program? Let's just have a discussion about where we are in 2025 with GLP-1s.
I want to say first, if you're doing a GLP-1, it won't be a dinner table, I don't think. So
I thought it. I was thinking it.
Well, depending on how much was on the dinner plate at that time, it might be worthwhile.
Yeah, we got to quit this.
This is a discussion that everybody is talking about, and it seems like everybody wants to be on them for one reason or another, whether or not they're morbidly obese or actually diabetic, or they want to lose a few pounds because they just gained a little bit of weight, right? And so how do we control the cost of these, and then how do we triage the access appropriately so that the right people are getting the right medication, but it's not a free-for-all? I know you got opinions.
It's interesting. So I'm doing a talk in 2 months in Wisconsin that literally the topic is GLP-1s have changed the PBM industry as we know it. And it's not just about GLP-1s. It's what they represent, because there will be a new GLP-1, and I can promise you. GLP-1s, one thing everybody needs to understand is these are not new in the last couple years. GLP-1s have been around since Byetta. I mean, we've had this medication. I have a physician I know here where she's right there nodding her head. So I need to make sure I have my drug names right now, because I am not a physician or pharmacist. But the bottom line is that GLP-1s became popular because they became popular. Thank you, Oprah, right? I mean, they became everywhere. And suddenly we saw them skyrocket, just like we did with specialty drugs. 2 years ago, this very question would be, what are we going to do about specialty drugs? Everyone's on Humira. I mean, it's just because of the marketability of them, and quite honestly, because they're working and people are losing weight. And so the question is again, it all gets back to I guess the third thing will be data and understanding how much of your population are on these medications, which ones are being covered. What do the clinical notes look like, right? I mean, what is the patient criteria? How many of them are type 1? How many are type 2? You know, if your company does choose to cover them for weight loss, what roadblocks have been put in place? And then finally, you know, where is that medication coming from, right? We are now done, for the most part, with the
compounding.
The compounding. Yeah. Thank you. I want to say biosimilars. With the compounding, the semaglutides, right? Everybody can go get their Botox and their semaglutide, and, you know, there's custom deals online. We're done with that. So we're going to go back to the manufacturers. So it's all about creativity. It's about the conversation with all of the vendors that are in place. You know, in some cases, members going direct to Eli Lilly is the answer. I mean, Lilly's got their own programs that are helping pay for these. So it's going to be a blip on the radar. The question, just like every other category of medication, is how are we managing the patient? And how are we keeping them on track and compliant? Because it gets real expensive if we're not compliant. And continuing to make sure, because those medications are likely to come down in the future. But
Stephanie, you guys cover them for weight loss on your plan?
So we cover them for people that are type 2 diabetics, so for medical necessity. Mm-hmm. And what I actually sat on a panel last year at a conference about GLP-1s, and my opinion is that a company, as long as they have a plan that is structured with what I call guardrails in place, so you have your predeterminants of someone being eligible, right, for GLP-1s, like a psychological evaluation, but then they have to be managed by a physician or clinician for however long the company wants to approve them, but then on the back end, they still have to be managed. It can't just be a free-for-all if a company's going to cover them.
The only other advice I will have is, if you do cover them for weight loss, to have it be a separate program, because then it does not have to go towards your out-of-pocket maximum and some of the other categories of medication. So if you are going to do a weight loss program, totally carve it out of your major medical and make it an opt-in so that it can be its own budget.
I like that.
Interesting.
It's a great point.
I would say I'm going to double down on what both of them said. Is the strategy has to be constructed by the employer on what works for their population. If they're in an industry or they have a population that has a higher rate of obesity, coverage of GLP-1s for weight loss could really help their people and prevent some very serious medical conditions that would occur down the line. Couple that with the fact that I think there's over 23 other conditions that I think are going through FDA approval right now that they want to use GLP-1s for. And then there's new GLP-1s coming to market. It's going to be, for lack of a better way to put it, the aspirin of the future. And so what does that look like down the line? Are they going to start prescribing it for children? And what guardrails are on the plan to protect them from that? Some kids who would have been professional athletes never will be if they're on GLP-1s since they're young. Wow. So what are going to be the long-term implications of the coverage? And to your point, how do we set up the guardrails on the plan to actually fit the strategy and the needs of the population?
Yeah. I was just curious if you ever see these on in bill review, or if you ever see errors in these.
I see.
No, I just meant because there would only be prescription.
Yeah. Okay. Well, so I think maybe the other thing is that you guys both mentioned or alluded to the fact that there's other ones coming down the pike. I've heard that there's an oral version that should be imminent, or maybe there is already one out. There's the retatrutide, which is the one that's in FDA trials right now, which is a combination, I think, of 3 different versions of the peptide, where they're showing 24+% weight loss for some of the folks in that trial in a year. So 24% of their body weight, which is obviously an astonishing amount. And so I think we're going to continue to see it cascade that direction rather than much of a pullback, which I early on, when these are coming and becoming popular to talk about, thought, oh, it'll be a blip, and all of a sudden there might be a huge side effect profile, and all of a sudden there's lawsuits, and next thing you know, nobody's touching it anymore. And that actually hasn't played out. So you're seeing they're going to continue to grow in popularity?
They're going to continue to grow and populate. And what is really interesting, raise your hand in the room. I'm going to turn a question to the audience because I'm curious. If you are either a consultant or with a TPA, okay, a lot of people, how many of you, and by raise of hands, have been contacted either in LinkedIn or at a conference by a new solution provider that only does GLP-1s and saving strategies? There we go. So what's really interesting is that there are, it's causing, what I think is so amazing about this one category is it's created its own offshoot of solution providers. And so there's obviously, everybody's trying to do something with it. And so everybody should be talking to all of them. I mean, somebody's got to have, a good trick for these. So I do think as we have more, what excites me is how much ingenuity continues in the space.
Yeah. Well, so why don't we change subjects here, and then I think in about 10 minutes we'll open it up to the audience, guys. So I'd love for you guys to start thinking about what you want to ask. Just raise your hand. We'll have a microphone coming around. But yeah, Kimberly, this is a subject that I think you wanted to touch on, and I think it's important to touch on as well, is the role of private equity in healthcare, right? And so what is the role, right? Sometimes there's a negative connotation with private equity investment and the assumption that money flows somewhere, then money's being made, and it doesn't actually do the business good or the industry good. I don't think that's quite true. I think it's demonized unfairly for certain reasons. But at the end of the day, what does the proper role of private equity look like in your mind when it comes to investing in healthcare? I want to hear your opinion there.
Sure. I think private equity could really change the landscape of healthcare doing it the right way. You look at the rural communities, we're losing hospitals. My parents live in Hope, Arkansas. They do not have a hospital in town. So the hospital is owned by the ambulance service, if that makes any sense, and the ambulance has to be shipped to Texarkana. So I think that private equity could really play a role in putting their money into these health centers that could be sustainable and lasting for healthcare.
Well, but how do we avoid, perhaps, since we were talking about misaligned incentives, right? There's always got to be the appropriate incentive structure in place. Yes, there's nothing wrong with making money. Yes, there's nothing wrong with investing in businesses that can grow. But how do we not pervert that process of making money throughout that transaction? I think you were nodding and saying yes. So do you have a particular comment you want to make on that?
I just, it's the whole healthcare equation. So whether it's a TPA, a PBM, whatever vendor you want to work with, we understand that, everyone's in business to make money.
Yeah.
It's just, sometimes it's just so egregious that, there's nobody, guarding the hen house. And that's what gets frustrating. And as I learned more about it, I was just completely mortified and just disgusted, quite frankly. And, my goal is to continue being a voice on behalf of HR leaders throughout the country to help educate employers, because we need to know.
Yep. Kristen, I feel like this is a subject you want to comment on. Yeah.
What I will say is, I think anytime a business or a solution or a TPA or a PBM is evaluating an investor, they come up with a strategy on how they want to see their business scale, right? So they get an infusion of cash from an investor that really helps them build out their model and potentially get an investment to help them further themselves down the line or further that solution down the line that would otherwise have not been possible. I think the terms of the agreement of taking the investment dollars determines what the trajectory of that company is going to look like. If they don't put the appropriate, have the appropriate assets up front or contractually agree to scale a specific way, I think that's where sometimes maybe things can change. But I think that's really important on how they set expectations on how they're going to be in business together.
And the only thing I'll comment on is, what I think is so fascinating is where we've seen the most PE in my eyes has been in the brokerage space. And to me, that's because that's where they're seeing the most profitability. And the people who are selling the product of the work that everybody else is doing is, there's talk about misaligned incentives. Yeah. And I think that is, and what makes agencies valuable is when they're getting all these overrides from all of the carriers. And so I'm hoping, getting back to the reform and the regulations, I'm hoping, because that's how we can, we can support the independent agents and the ones who don't need those overrides because they're doing the right things and that they're selling the right services. And it's not because they're looking at an aggregate check that comes on the back end. And so, because when I hear that, private equity is not putting the money into the actual, health side of it, that's a travesty. I mean, because that should be, the hospitals and the physicians should get paid fairly. I mean, I don't think we want them to get paid fairly. We want people to go into that profession, but it's a matter of, where the dollars are.
Well, so I'll give you a specific example of the balance I think that needs to be struck. So I was talking to a consulting friend a couple of years ago, and he was at a relatively small independent shop, and he was evaluating going to be a practice leader at a very large agency running one of their offices. And we were going through the discussion to say, well, what are the pros and cons, or what are the trade-offs for you? Because when he thinks about what he was able to do in that independent firm is exactly what he wanted to do, but there was a scaling problem. He only had access to so many resources, and so it was hard to go sell new groups and be able to do it for as many as he wanted to, because there was the back-end servicing of that those accounts once they were sold. Well, the other part of the equation is now I go to a place with really infinite resources. Maybe I can 5x my block of business, but am I doing exactly what I want to do with each individual employer without any constraints? And so ultimately he came to the conclusion, I'm going to stay where I am and serve those customers exactly how I want. And if I can't touch 10 times as many, I'll be happy with the ones that I actually do impact. And I think he was ultimately happy with that decision.
Chronic health issues, surprise out-of-network medical bills, inflated medical and prescription drug prices. These issues cost self-insured employers hundreds of millions of dollars every year. Add to this the rising cost of care and potential for waste across the life of a claim, and it's clear that self-insured employers need innovative solutions that lower their health plan spend. At Valence, we've done just that, developed innovation that shifts the current paradigm. A complete and integrated ecosystem solution driven by data, one that manages and simplifies the complexity of medical claim costs. It is through analyzing millions of data points that we enable employers to realize and fuel cost-saving solutions. Valence experts come prepared from day one, targeting the fraction of claims that will drive the majority of health plan costs. That is how our team lives the Valence promise, engaging early and often for smarter, better, faster healthcare.
So why don't we do this, guys? Let's go ahead and open it up for questionings. We'll get closing thoughts from the audience. I see some hands shooting up. We'll go to Keith in the back. We'll get Keith a microphone real quick. Give us 1 second to get it over to you.
Thank you. By the way, Keith Lemmer, CEO, WellNet Healthcare. Spencer, great session. And ladies, thanks for joining today and great topics. This is a question for everybody. And maybe start with Kim. What question do you wish CEOs, CFOs asked when it comes to benefits, right? When they're evaluating that you feel like they typically don't?
Great question.
I'm going to pass it to Kristen first. Think about that.
Yeah. How much time do we have?
Right.
Yeah. I know.
That's a
Specifically, CFOs and CEOs.
When it comes to evaluating benefits, I feel like most, offshoot it to the HR, to their broker advisor, right? And they don't get involved. But if you had a CEO or CFO involved in the meeting, what's the type of question or questions you wish that they typically ask that they don't?
If the process is not centered around education and understanding where they are today, and I think first we need to understand what their objectives are. A common theme I would say is usually it's how much are we going to save, and if it isn't on the spreadsheet and showing a minus 10% versus where they are today, they're going to move past it. The challenge you have is they are let's talk about fully insured employers for a second. HR is managing majority of that, and you're not getting involvement from a CFO or CEO in that. We hear this a lot from employee benefits producers versus PNC producers. PNC producers have a relationship with CFOs and CEOs because they're doing risk management. The employee benefits side, they're not involved. When they are involved is when their head of HR comes to them and says, we got a 40% increase this year and we're not budgeted for it. Reaction number one is fire our benefits broker and let's find something cheaper.
Or switch carriers.
Or change carriers, right? Instead of it being a discussion about what we're doing isn't working, how can we all collectively come together, HR, C-suite, CFOs, and figure out a game plan, not just for the short term, but the long term. Get out of your 12-month increments, because that is the carriers training us to think that way. How do I plan this magnitude of an expense for my business for the long term? And how do we get the most value out of every dollar we're spending on healthcare over the next 2, 5, 10 years, depending on their business strategy?
Great response.
Yeah, I was going to actually comment and say that if employers do not think that they are in the healthcare business, they are sadly mistaken. Every employer is in the healthcare business, whether they want to or not. So that's my bottom line.
Coming from a PBM side, I wish every CEO would ask their wives what medications their kids take before they change vendors. No, just kidding. But that's one of those, if you know, you know, the room. No, all kidding aside, I wish CEOs took more of an interest in the whole picture. To quote a little bit of Dave Chase's original book that started the Health Rosetta movement, what is the title? It's whatever. I can't think of the name. We all know the name, but basically where he points out how many, again, misaligned incentives are within their own brokers, and understanding if their broker gets paid more when they go up in premium more. I think CEOs need to understand how every piece of the pie is working, and ask just, how the broker, why he's bringing the various solutions to him, and understanding also and having a pulse on how their own employees utilize the program. And, because some CEOs have the mentality, I want the best, I want the name on the card, I want this, and tell it, and HR go run with it. But sometimes the employees don't want that. And I think it's just listening to their people.
Yeah, definitely. Kim, what were you going to say?
I've actually forgotten what I was going to say. There's a lot of things I wanted to say.
Well, hands were shooting up. I don't know who was next, Nathaniel or Dustin, whoever's got the mic. If you'll just pick, keep your hands raised, and we'll try to get to everybody, okay? Where are we going next here? We'll go ahead to Austin. Yeah.
Great show, and thank you, everybody. Great to see clients and friends. What solution are you seeing that's actually getting at the root causes versus treating symptoms? And why is it working?
Love that.
Okay, all right. Root causes versus symptoms. Specify your answer a little bit more, Austin. When you say root causes, within a benefits plan, a specific type of solution, or what are you asking for?
Well, I'm in behavioral health, so I could talk about that. But an example would be like root causes, gut biome health, driving a lot of other things, or root causes and other types of factors that are causing the issues. A lot of allopathic medicine treats symptoms, so it doesn't treat causes.
Well, so on that subject, and it's just pertinent because it's top of mind, and we released an episode on Tuesday about this very subject, about root cause medicine or functional medicine. So I've long since thought that the way that we actually control healthcare in the United States is we actually improve the average baseline health of every American, right? And until we do that, we're somewhat shuffling the chairs on the deck of the Titanic. And so functional medicine is more about identifying root causes through allergy testing and blood testing, and then recommending supplementation and vitamins and other things in addition to that. And I think pharmacogenomics also play a role in that, and identifying at what genetic level, how a person is going to be impacted by drugs, rather than just throwing everything at the wall and seeing what sticks. I think we'll get a lot more precise in the way that we apply or recommend drugs here in the very near future. What do you guys want to add?
I want to say a root cause a lot of times at the plans is, let's make everyone that's involved in the plan, let's make the carrier, all of them fiduciaries. Let's not just put it off on the plans, the employer. Let's put, everybody should be responsible for the work they bring.
Yeah. I was thinking about root cause, and we're really pleased to also work with Austin's team at Shoulder, and that was a new complement to our healthcare plan this year. And what I'm thinking about with root cause goes back to employers taking care of the employees. A root cause, in my mind, is understanding what the foundational issues are with their health, which is primary care, preventative medicine, preventative wellness, and using that as a foundation to continue to build on treatment plans for those individuals. So that's how I look at it, as foundational.
Yeah, I'm actually personally going through the acquisition. I did a pharmacogenomics report just to understand how my body reacts to certain medications, and it was very insightful. Also finding out that certain medications would likely kill me that I've never taken before. So that's good to have in your medical file, 100% to have to go down that path. But I think functional medicine is an important one, and I think there's a lot of solutions emerging. I think pulling it all together, right? And having an advocate, like I would probably pride myself in someone who can advocate for themselves and understands the system. And it's still hard because you deploy all of these solutions, but if you don't have something that's pulling it together and informing your medical plan or your medical strategy in partnership with your primary care doctor and others, it's hard to figure out what to do, because the advice you're getting in the traditional setting is to treat the symptoms and to treat chronic patients. And what other medications can you be prescribed to manage those symptoms? And on a scale of 1 to 10, improve you from a 5 to a 6. Versus functional medicine and other areas of medicine are going to get you to what is driving these factors for you, and what can we deploy, or how can we figure out what's driving that and then solve for it. And sometimes it is medication that's going to help you with that, but there are other factors that are harder, like lifestyle changes, diet and exercise, supplements are going to help you get to a healthier place in life.
So this for some reason was like an SAT question in my brain, where I was like, doing like a back and forth. I'll just say something that I think is misspoken. It might be the same anagram that you're looking for. I hear a lot that people are very unhappy with TPAs in this space. And I'll say, why, they are terrible, or they did this wrong. And I'll say, well, what sucked, if you will, sorry for lack of a better term. And they'll start saying things that truly weren't the function of the TPA. It was one of the strategic partners or one of the ancillary vendors or solution partners. And so I think that if you're going to talk about a root cause, I don't think that all TPAs suck. I think all TPAs are doing their job. It's you as a consultant or employer or patient have to understand who to go to. And so this, to fix that, it's that making sure all of the vendors understand their role. Make sure you're collaborating with the various teams. And, there are very creative consultants that do meet, listen to how many vendors she's just mentioned in this room, and they're all independent companies, but she's quarterbacking that and making sure that they're all working. And that's what we all have to do, because when you start to point fingers, you have to realize maybe it's because what you expected of one vendor wasn't really the role that they were hired to play. And so I think, to get to that question, I think it's just making communication and open alleys of dialogue. Mm-hmm. Oh, there we go.
Keith asked that one. All right, so let's go into the next question. Keep them up. Just hand the mic right in front of you. Make it easy. We'll get to all of you guys, I promise, for sure.
Yeah, so Matt McEwen with Imagine 360. Stephanie, I think it'd be impactful for the listeners and the audience to hear, at your first employer, when you rolled out alternative strategies, what you did to communicate that initially versus what you learned from feedback, and how you rolled that out to sell the win to the employees.
That's a long question.
Yeah. So it's about kind of the communication process itself in that transition. Is that what you're looking for? Okay.
Yeah, the reselling to leadership, what you took away from that meeting, and then how you rolled it out to the employees as to how they won your approach on medical pharmacy.
Well, I'll try to give the Reader's Digest version, but I will say as an HR professional for many years, the first time I heard that we were probably moving to reference-based pricing, I said, you guys are absolutely out of your minds and it's never going to work. So that was me 10 years ago. But the point is that when we rolled it out to the employees, we actually did a test presentation to middle management. I think that's what you might be referring to. And we actually wanted to run through our communication with a test case. So these were all the managers that were managing most of the boots on the ground. We got done with the presentation. We're all excited. And one manager raises his hand and he said, well, that's great that the company is going to save money, but how is it going to impact me as an employee? So we had the oh crap moment. We have to rewrite this presentation, and we wanted to make sure it was then employee focused. And we were able to be very successful flipping that script and communicating it to a point where they really understood how they were going to win during that process.
Yeah. Awesome. Okay. Would you mind handing it right there?
Hi, I'm Elaine Davis. I'm a Chief HR Officer at Motive Health, and before that I was Chief HR at HealthComp, which is a very large independent TPA. I've had a long career doing a lot of different things. And I want to say two things. Just on the RBP, just for, because I used ELAP at a company, is I called every single hospital in the regions where I was putting in RBP ahead of our planned launch to make sure I smoothed the path for people. So it was an enormous effort. But don't get me wrong, it was not easy. But that's something that was a learning for me, was call providers where you have large portions of employees and smooth the path. Don't leave it for the employee to be standing there with their card in their hand saying, can you call this number? I really do have insurance. That's not a great way to do that. But the second thing, the real thing I wanted to say was, and Kristen knows this about me, I, as a CHRO, whether it was at GlaxoSmithKline or whether it was at Motive Health, I'm the most powerful person in that company. I'm running the salary line, that's number one. And I'm running the U.S. benefits line. That is number two. Yeah. You add those two things together, and I control more of that company than anybody else in that C-suite except the CEO. So I reject the notion that I'm an offshoot in a conversation between a CEO and a CFO and maybe a broker. I totally reject that, and I don't mean that meanly. I just mean I have never been allowed anybody to say, well, just go ask the HR person, maybe she can figure it out. I've always been in the room. And so my point is, much like Stephanie, stand up. You're the most powerful person in that company. You're controlling enormous expense in that company. You're responsible for it, and it gives you leverage, and you need to use it.
Yes. We're going to go on a road show, her and I.
I think you got your mic drop.
Yeah, we did. Yeah.
So we're going to go on a road
we got
show.
A couple more. Well, so thank you for that. Excellent job. Let's pass it on over to Omar.
Hi, everyone. Great job. My name is Omar Arif. I'm the Senior VP of Growth at a company called ClaimDoc. And my question is for Kristen and Kimberly. Since we're on the topic of being a fiduciary, I just want your opinion on this. If you're a self-funded plan and you buy a PPO network, knowing that PPO network is going to auto-adjudicate 95% of all medical claims, even really large medical claims, are you in breach of your fiduciary obligation if, say, a large inpatient claim gets massively overbilled and paid?
It's a good question. I was looking for a legal opinion. I think we only have one lawyer up here.
Okay. Do you want to go?
I think the suggestion, obviously, Omar, is very likely, right? But what's your opinion, Kristen?
It's possible, and it depends. Isn't that the lawyer answer you're supposed to give in that scenario?
I'll let you take it.
I think, there's posing a question like that is going to cause an employer to pause and think about it, right? I think that a lot of education has to occur before, from an employer's lens, when they have a fiduciary obligation, that they're even going to understand the implications of that situation for them. right? So understanding that, we talk to employers all the time, and you know how it goes. Like, we've had multiple conversations about California. To even bring up the topic of something around, like, you need to dismantle the typical network and go direct or use reference-based pricing is very scary and not a common idea or anything that people sign off on easily unless they're in a situation where they have to do it. The way you pose the question is probably the right way for them to think about it differently, to say, what would happen in this scenario? Then what implications does that have to me as an employer for me to think differently about my strategy to ensure I don't end up in that situation? I think it's a different way of thinking about it. I don't know the answer to your question, but I think it's a good question to pose to get people to think differently, because based on where the legalities are going associated with this, the likely answer to your question is yes.
Okay, I'm a sponsor, so I get a second question, don't I?
Wait, so sponsors get two questions. So, yes, go ahead, claim doc.
Kimberly,
yes.
I've recently become familiar with your work on LinkedIn, and I'm a huge fan. I don't know if you track this or not, but what would you say is the delta between let's use a large inpatient stay as an example, between the original billed amount and the adjusted billed amount after you get your hands on it and you do a full bill review?
I think it depends on the contracted rate between the carrier and the hospital, and I always try to get my hands on that, but it takes months, and then they say they have to pay the claim, so I never can get it. But it's typically it's hard. It's very difficult, and that's one of the biggest problems, I think, is not being able to get our hands on the contracts. Yeah. But if I find a claim and the contracted rate, I just reviewed a $150,000 claim, it should have been $25,000. Yeah. But there was a contracted rate there, and there's nothing I can do about that.
Yeah. Yeah, I've heard it estimated, you probably have an opinion on this, Omar, that roughly 40 to 50% of healthcare spend is likely wasteful of some sort or overcharged, right? And so I don't know if directionally that's probably true. We could probably never come up with an exact amount, but realistically, we all know there's exponential charges happening in those contracts versus what you guys are able to procure or versus Medicare. And so I don't know the exact number. If Kim can't get a hold of it,
there was a contract I did get a hold of, and I actually posted it. Y'all may have seen it, but they charged, was it 600 times for specialty medication for the contract between the carrier and the hospital, where they were able to charge that. They were also able to charge for a robot, which was $100,000 they were charging for the robot. So I was able to get that contract, and I disputed it as much as I could. I took it to the Attorney General, but nothing was ever done. So it's a matter of making people aware and trying to hold them accountable. That's all we can do.
The problem, I think, with everybody is just how complicated it is. And that's what's so hard. It's, my personal story, I have two of them. My father's a physician, and, sometimes we talk, and I asked him if he would be happy getting a percentage of Medicare. And he was like, all day long. And I'm like, did you not know that's a thing? Like, he had no idea. Yeah. As a physician in a, family practice where he's independently owned, he's not owned by a hospital. And I just think and why is that? And it's like, why isn't what, Kim just tried to make go viral more than viral in our ecosystem? It should be like, people should be outraged. And I just hope we keep talking about it.
Well, Rachel, to your point though, and we did an event a couple weeks ago in Lubbock with the hospital system, and we haven't released a podcast yet, so I can't say who, but there was a hospital system at the table, that CEO with the high performance network, with a consultant, all sitting together, just agreed upon a program that they were about to roll out. But that CEO was saying, I want to do this for these people in this market. We take care of 700,000 people or so in the metro area. I want to be paid quicker. I want to be paid fairly. I want people to stay in the system and get the care they need without impediments. It was actually pretty refreshing to see the supply side of healthcare say, bring me to the table and negotiate with me, and we'll negotiate a fair rate.
That's very rare.
Yeah.
But I think we're seeing more of it. I really do.
I think I see the bad side of healthcare, honestly, because
fair enough. Yeah.
I don't. When you have a lobbyist, when you live in a state and you find 64% of savings in the state's health plan, and you have a lobbyist tell you that if you pay him enough, you'll get in, but if not, the other person will get in, and the same person that is administering those claims, the only ones You use their network, they have to be your TPA. When you've got government going against you, you can't win. You really can't. So how do we as healthcare advocates deal with that?
Rhetorical question.
It's the question of the day,
Yeah.
So speaking of questions, I want to see if we can get a couple more in here. So Chris, you've got one. Yeah, go ahead.
Hey there. Chris Matthew with WellGenie. My question is around GLP-1s. So you mentioned that, Rachel, that the compounded version, we're past that. I don't know that we are. I'm not challenging that. Just this question about, especially you mentioned, Kristen, if there's 20 plus new diagnoses that will now be able to be treated with GLP-1s. If it's right now, employers are covering this for type 2 diabetes, come next year, it could be a whole lot more. So if this is already impacting health plans today, it's going to be a sizable impact moving forward. How do we start preparing employers to realize this issue is not just a trend about weight loss for diabetes, but it's about to impact lots of states of disease? How do we prepare?
I'm just going to clarify, and I'm going to let you take this question. I think what I meant by we're done with the semaglutides is, health plans aren't covering them anymore. A lot of the places that we're able to bill, like PBMs, et cetera, they cannot any longer because of the cease and desist from the manufacturers, is what I was referring to.
And I might have a little bit of a cynical approach on this, but when something happens in our industry where it's like you can't compound anymore, they're going to compound in a different way and define it differently and call it something else, and it's going to pop up in a different way always, right? From an employer's lens, like think about a couple of the conditions that they're under FDA approval for right now: infertility, metabolic disorders. That is very broad. So employers have to be aware, and, education with their consultant and the partners that they're working with is key to understand when these approvals happen. How do they want to design their benefit plan to, one, decide if they want to provide coverage for this, if it is approved, and then two, how are they going to control that expense or source the medications at the best cost if they do choose to cover it for those reasons and feel like that's the best choice for their population? That would be, it's not a straight answer or a roadmap, but I think it's going to differ, and they have to build what that strategy is going to look like. And it has to be a multi-year strategy. Implementing one thing in year one, seeing how it affects their population, and then continuing to evolve that, I think is important. It's not a decision they're going to make and then set it, because that's right now that there's 23 plus conditions in front of the FDA right now. There's going to be more drugs. I think there's versions of these drugs that also, they have not compounded versions, but different versions that also prevent the muscle loss associated with it. Wow. Are those going to be approved for it? What's the cost associated with those versus the ones that are on the market today? So this strategy is going to evolve, and I think it needs to stay front of mind with employers and their consultants to design their plans to address these things as they change and occur. Kind of to Omar's earlier point, like definition of fiduciary, and are you in violation of your fiduciary obligations in the scenario he described? The definition of a fiduciary is also going to continue to change over the next few years. So it's something that we all need to be educated on as healthcare advocates and continue to advise and work with employers and ensure that they're making the right decisions for their populations.
And I think the key here is understanding it's a conversation. Employers don't realize that they can get this granular with their own plan design. And that is the key, is making sure that education piece, it's more than just data, it's what you do with it. And understanding that they can work with unique vendors and really structure their plans down to the formulary, and working with PBMs that allow you to do so.
So why don't we open up for one or two more guys who raised their hand? Yes, I forgot. Chris, if you don't mind, or Nathaniel, come around and pass that. Thanks, Nathaniel. All right. Yes, go ahead, sir.
Thanks. Hi, I'm David Rose, Chief Channel Officer at Talon. We're in medical shopping price transparency. In fact, if you don't know, we're the group that the White House brought in to model national transparency for the nation. So my question is going to be in that line.
Okay.
Curious. And by the way, thank you, Spencer.
Yeah.
Great panel. Love the discussion. I'd love to hear what you all would share as what you see the future impact of medical shopping price transparency with employers. Granted, it's a pretty new subject. Just became full-blown rules and laws ratified as of January 1, 2024. Very new. Find a lot of employers and HR leaders not really knowing a lot about the subject. TICRA, Transparency and Coverage Rule, Consolidated Appropriations Act, No Surprise Act, major things that impact actually revealing prices of healthcare to Americans so we could shop it like anything else. And we've talked about pharmacy. This is key. Medical procedures, 75% of the total holy grail, the medical spend for an employer. So I turn it over to you all, panel. What do you see as a future impact with medical shopping price transparency?
Yeah. Let's take that one. I can go. Stephanie, you want to
I guess
start?
my initial comment, and it's what my perception is that hospitals and providers are supposed to be disclosing pricing, right? That was part of it, but I don't believe that's happening. And I think there's still information that's not being made available so consumers can make informed and educated decisions about what they're spending or what they're spending it on. So I still think there's a huge challenge.
Well, can I comment? I was going to say, I can see it on a micro level as an example where I can see a very direct use case. We partner with an entity, Valence is here, but they have something called the KISS card. And so KISS card is outpatient imaging and outpatient procedures where there's direct contracts within a network where a member can be incentivized based on knowing what the cost is of that procedure, incentivized to go to this MRI facility versus this MRI facility because it's going to save the plan money, and the incentive to them is we'll waive their out-of-pocket costs, right, as an example. So that's a very microcosm example of if you give them the information and if you make it simple to understand, most people will make the right decision in that situation. I think your broader question is how do we scale that up? How do we make that so normal every single interaction with the healthcare system is shoppable like going on to Amazon? I don't have an answer for that. I would love to see that, but I think we're probably very far away from the
Can we just put a price tag on everything and know what we're paying for, and maybe things would be a little easier?
And that's what I always say, like what company writes a check for something they don't know what the hell they're spending their money on? They're spending money every month for healthcare without a receipt of each of the transactions.
But they know what the pencils cost.
Well,
every other line.
I'm going to worry about how many boxes of paper clips or how much coffee we have to buy, but let's not look at the second largest line item,
I think Rachel's dying to say something.
I just was going to say, I think it's also so dependent on how it impacts the patient. I think that, we saw high deductible health plans as this whole, way to like really create educated consumers. Did it work?
It had the opposite
effect. It had the opposite effect. And so I think that, to your question, how transparency is going to scale and impact, it's when the patient at home not only understands, how to get to the price, but what is in it for them? That's what people care about.
Yeah.
It's if they have a $5,000 deductible and the surgery is going to be more than $5,000 at every single hospital, it doesn't matter. They're going to go with the least path of resistance, and they'll, there's a lot of strategies for that $5,000 deductible, I know, but the thing is until you're waiving that deductible or you're doing something that gives them that incentive and it's simple and they understand it and they can go on their app and they can like, go here, it's free. Oh, great. That's where I'm going. That's where I think we go in the future.
Yep. I guess we got time for, okay, we'll do the last two here. The folks have their hands raised.
Hey guys, great panel. Spencer, amazing as always. My name is Emil Patel, co-founder and CEO of Miko Health. My question, I guess, is more from a clinical perspective and maybe a technology perspective. It seems like we have troves and troves of data. Rachel, you mentioned something that just really clicked for me, which was, the value of a PBM being this kind of this Wizard of Oz behind the curtain, making sure that things are happening correctly for patients that are going to bespoke pharmacies, maybe even across the country, right? But like checks and balances are important. And thinking about the data that exists on the provider side, on the TPA side, do you think there's opportunities to bring technology in a way that like that kind of coalesces everything in a better way to provide clinical value to patients? I think about the conversations that we have, at least that I've had, are consistently about cost. Yeah. And it's like there must be something that we can do on a clinical side to even negate the question about cost down the line.
100%. And this impacted me a week ago and frustrated me. And I'm very sad that I'm about to tell a story and I cannot think of this poor child, not a child, an adolescent name. There was a kid a teenager who, maybe he was at late teens, but he passed away because his PBM changed formulary. Now, whatever's right or wrong, I'm not going to pick on the PBM necessarily, but we have the technology and we have the data. We have data to see that somebody was on a chronic asthma medication, right? Every month he had filled the same asthma inhaler. He went to fill it one day and was told it was too much money, and the parent story, and he left. He never filled it. Well, there should have been some kind of technology that went to the provider that writes this medication because he had to have it to live. And so yes, I mean, we have the technology, we have the data, we've got to put it together and get the providers back involved because that could have been prevented. It could have been, why didn't you fill this? And, and he could have said, I couldn't afford it or whatever, but somebody should have known that this person who had taken inhalers every month of his life didn't have it. And I think that's where I think your question is going is we're not using it correctly.
There's fragments in our system, to double down on your point, that people fall through those cracks all the time, and it costs some of them their lives as a result. We have the technology, it's available. It's what solutions can we deploy to create, like to their points earlier, incentives for people to engage and care about the transparency, and then to make it easier for them as well. Make it easier for them in different ways, not only from a care acquisition perspective, but also solving for the gaps that could lead to saving someone's life or making their health much better or preventing them from having to go on certain medications because they have access to a solution or care that could help them and solve for it instead of making them a chronic patient. We have the technology. I think that development of those solutions is critical to solve for a lot of these gaps and fragments in our system that lead to costing people their lives.
Well, I think what you're really describing is a true and robust independent version of care navigation that actually understands the components of the plan. So not just what pieces are in place, but how does the plan function, and is able to get to the employees and actually get those employees engaged and want to engage with that entity so they can direct them through that episode of care or that journey. If that layer is missing and your population is just at the mercy of making their own decisions and trying to understand the plan, you'll get outcomes like that.
Well, yes, and from my perspective, I think if you have to engage the member, it might already be too late. If we're doing this correctly, we would have engaged the provider upstream, and that the appropriate care would have already been delivered.
Fair. Yeah, absolutely. All right, last question in the back.
Great panel, you guys. My name is Kaylin Carleson. I'm with Private Health, and I have a question about high-cost claimants. I run into it all the time with individuals or employers and brokers who are really stumped on what to do when it comes to high-cost claims. So what solutions are you finding that are working to mitigate the costs and drive better health outcomes? And then what do you find that there's gaps and opportunities?
Okay, so the question is about high-cost claimants, and I think there's probably a multifaceted answer here. So, so why don't you go first?
I'm probably going to be giving it this direction, but the first thing is it starts with the SPD. Because with high claimants, there are all kinds of strategies. Again, we went to episode 400 just talking about PBM. We could go to episode 1,000 with strategies depending on the diagnosis. But the SPD has to be written in a way that you can actually do those programs. And I'm going to gear towards both of you. And
I couldn't agree more. And I think looking at the drivers of what those claims are and being able to deploy proactive solutions, whether it's on the pharmacy side. You talked about a 600% markup when someone's getting an infusion in a facility versus an at-home. Somebody said it.
I did.
Okay, you said it. 600% markup for them to get an infusion somewhere. That's if we're talking about $850,000 versus, much less than that. I think people have, or a lot of folks in our industry have let it become a large claim. Now, what do we do about it retrospectively versus what are the ways we can design our plan to deploy solutions to address these things proactively? What's working, what isn't? I think there's certain categories that need more solutions developed, but specialty pharmacy infusion spend are low-hanging fruit areas where plans can be designed to solve for that. Medical large claims, I think and this probably doesn't apply to every area, but one area of opportunity I see is there's a lot of focus on driving down the cost, but that needs to be coupled with a way to help the member through that journey and enhance the benefit for them so that they're getting the engagement in the solution to really help them, and the byproduct being savings on the plan.
The back end of that question, though, so that's more on the prevention side or the triaging side. The back end of that question is, how do you afford to pay for or cover when there's very, very large claims? So a stat for you guys, if you haven't heard it before, we partner with HCC. They did a block of business review. They do a study on their stop loss block. It's about $2 billion of stop loss. The last 3 years alone, $2 million claims have gone up 14.5 times. So 14.5 times more frequent than they were 3 years ago. A highly credible block of business. So the other side of that answer is you have to make sure from a stop loss partnership, whether it's a captive or traditionally self-funded, your stop loss policy will protect you not in just this year when you have a very large claim, but multiple years in the future as well.
Yeah, I agree with that. And one of the things I was going to also add in our stop loss arrangement that we have, we're in a consortium. And when I got to Hendry 5.5 years ago, our specific deductible was $80,000. And at that point in time, we had several high dollar claimants. But as the years went on, every plan will have its history of high dollar claimants. Those did get reduced. So the out-of-pocket expenses for those went down. But what we ended up doing was we understood the risk involved with what we were going to spend for the premium. We ended up increasing our specific deductible to over $100,000 because we knew we were taking on more of the risk because our high dollar claimants were going down because of the strategies we were implementing. So it works in tandem.
Yeah, absolutely. Awesome. Well, guys, why don't we do this? So it's right around 6 o'clock. I really appreciate you all. Real quick on this panel, let's go ahead and summarize. You guys have the opportunity, each one of you individually, closing thoughts. What do you want this audience, and the audience obviously online listening as well, what do you want them to be thinking about? Go ahead, Kim.
I'll go first. So US Beacon is an independent third-party review. Do not allow the fox in the hen house. That is where you will get yourself in trouble. The laws are in place to review your claims, to review your documents. Use them. If you don't follow me on LinkedIn, I'm a very big advocate for this. Kimberly Carleson, or you can go to my website, us-beacon.com.
Or is that somebody? You got a purse left over here. Is that your purse? Okay. Somebody didn't like your last statement. Somebody's listening in here.
Yeah.
But so let me say this while that's ringing. Just definitely follow Kimberly online on LinkedIn. If you do not, just throw the purse against the wall. But yeah, so follow her. If you do anything, follow all these lovely panelists, but definitely follow her if you're interested in that bill review. Fantastic account. Go ahead, Kristen.
I'm going to go with the same theme of do not accept the status quo, from thinking of the employer's lens and empowering the employer and thinking differently about their strategies and what they can do. If you're not working with people who are helping you move past escalating your business and really solving for your business needs and using your benefit strategy to do it, find the people who will work with you in doing that. This room is filled with healthcare leaders and change makers and people who are advocating for the voice of the employer. And I think that's critical for all of us. It doesn't matter if we work for competing solutions. Right. The fact that we're all proponents of helping break through the status quo, do something differently, fight against misaligned incentives, don't let the fox guard the hen house, and really keep pushing forward for change, I think is important.
Excellent.
And thank you all for being the esteemed panel.
Yeah.
No, and I'm just thrilled to be here because as an employer, I like to speak from my lens. And I think it's important for everybody who's a solution provider or broker or what have you to understand that, from the HR perspective, again, you have to be patient. You have to break things down. We're not going to assume. Don't assume we understand everything that you're talking about. So be patient, but also don't not come to us with solutions because you assume we're not going to be interested. So definitely come forward because, we have to rely on experts to make us better professionals in our field. So.
And my takeaway for today, actually has nothing to do with PBM. It's about finding more Stephanies. All of you in the room have clients and that you've done good jobs for. We all are employed, thank God, right? And we all have clients that we've done good things for. We're so concerned about spreading our own brand messages and talking about how we did this for them. Let them talk, because the more employers we get out there saying that these solutions work and giving them that voice, I really think we will make that much more change, because, and it's referrals, right? So it's a double-edged sword, because you've got to get the employers out there and talking. So I love doing this with you, because it's why we have our jobs, to hear the stories like you tell.
Well, so the last thing I'll say, guys, is the purpose of the system is what it does. You may have heard that term before. And so what that means is whatever outcomes you're getting by participating in a system, that's what that system is designed to do. So how does that apply to healthcare? What are the most common outcomes employers are getting today? Rising costs, worse benefits, right? So then it becomes a foolish errand to think, if I'm in that system, that one day it's all of a sudden going to change and I'm going to get the outcomes I want. And so what I would proffer to employers that are on the cusp of making decisions like this is, if you find yourself in that system that you're not getting the right outcomes, you're at a crossroads and you have to ultimately decide, do I want to participate in a different system if I want a different outcome? And most employers haven't been ready to make that step. But my hope is through conversations like this, that more of them will be, and everybody in this room that plays a role, we're all advocates for change here as well. And so I can't appreciate you guys more for being here. Definitely appreciate the panel. Thank you guys so much. Yep. Give them all a round of applause, please, if you don't mind.
Thank you.
Awesome.